This episode of The Poison Lab is sponsored by Evoke. Anyone who works in healthcare right now knows that turnover is real, especially after the COVID-19 pandemic. It feels like we're losing experienced team members every month sometimes. People who should be thriving in their careers, not walking away from them. Healthcare is built on dedicated professionals like you and me, but right now, the stresses we all have to deal with continue to push people out of the field. That's where Evoke comes in. This isn't another pizza party or generic wellness module. Evoke is an interactive app, backed by 40 years of research and designed specifically to help with unique stressors faced by healthcare workers. It starts with a quick assessment to identify an individual user's needs, then delivers bite-sized interactive sessions on critical topics like secondary trauma, conflict resolution, and self-compassion. I'll happily endorse any tool that helps frontline staff better deal with the stress and burden that gets placed on them. Learn more at evoke4work.com. That's evoke, the number 4, work.com. Hey, it's Ryan, and before we jump into this episode, I have 2 quick updates that I think you're going to like. This announcement is going to take exactly 5 minutes, and because I really want to get the word out, it's in front of most of the episodes. Since my intros are somewhat long with lots of disclaimers, I always put timestamps to let you know where to jump to get to the show. But if you're listening to this message, please add 5 minutes to whatever I say in the intro. And feel free to fast forward if you've already heard it, since it's in front of most episodes. I promise I'm just leaving it in front of these episodes for a limited time. The first update, the Poison Lab is almost finished with its Poisonous Mushroom card game. Yes, I know that is deeply nerdy, but it is also so much fun, and it's sneakily educational. The game is called Gotta Pick 'em, which is named after a mnemonic created by toxicologist Dr. Richard Hamilton. But that's not what this is about. Check out the episode A Mnemonic for Poisonous Mushrooms with Dr. Rob Bassett to learn more. What we are here to talk about is the game, which features over 55 individual poisonous mushrooms. You get dealt a hand of different mushrooms and antidotes, and you can forage one of them. Then you pass your hand to the next player and get a new hand from someone else. You score points by collecting mushrooms with the same toxin in them. And because I'm a huge nerd, the scoring systems actually complement the toxins, where things that cause late toxicity get you points later, chronic toxicity builds up over time. There's actually 15 different ways to score. It's really fun. And you get bonus points by collecting antidotes for the mushrooms, grouping them by specific physical features or by places they grow in the world. If you've ever played the popular game Sushi Go, it's a lot like that. But instead of collecting sushi, you're collecting deadly mushrooms. And you get to learn more about them because the game was created by people who actually treat mushroom poisoning. It teaches you which mushrooms might be poisonous, basics about identification, where they're located, all the different toxins, their antidotes, and the organ systems they impact. But you don't need to know any of that in order to play. It's actually just a really fun game. I've beta tested it rigorously with my non-medical friends and family, and they all said it was a blast. We're still ironing out production, and it's not ready for release just yet, but you can still check it out. Go to the show notes or head to our website, thepoisonlab.com, and look for the Gotta Pick 'em link. It'll be on the right-hand side. There, you'll get to check out examples of cards from the game and sign up for the newsletter, which will keep you up to date on any release information. Supporting members of the Poison Lab are going to get early access and a discount code when it launches, which I guess takes me to my second announcement, the part where I confess I'm officially out of free software trials and channel my inner NPR pledge drive. The Poison Lab is officially joining the world of listener-supported media. And honestly, that's a weird sentence for me to say out loud. I started this podcast because I just love the field of toxicology, and this helped me scratch that itch. And I wanted to share information that might help improve the care of poison patients, or at least let people know what poisons are out there. Because I just love making this show, the idea of it ever becoming funded was sort of foreign to me. And if I'm being honest, I've always had conflicting feelings about monetizing medical education. Although it does seem to be just about everywhere. From MRAP to MCRIT, curbsiders, you name it. It always made me think, do you really want to educate, or are you just in it for the sweet boat money? And here I am, 5 years later, totally boatless, and I get it now. I'm not buying a boat anytime soon, but those guys put out great content, not just because they're gifted clinicians, but they have the resources to do it regularly. I really want to grow this podcast. And it does cost money to make. Website hosting, audio software, recording gear, and actually now I'm working on something much bigger, a deep dive series on poisoning outbreaks. And for that, I actually need help from sound engineers and editors to make it sound as good as the story deserves. If I want that MRAP level quality, well, I need MRAP level funding. So that's actually why I started running ads on the show, which many of you have heard. But I know that's not everyone's favorite. So now there's just another option, listener support. Starting at just $1 a month or 2% of an annual MRAP subscription, you can become a Poison Lab supporting member at www.thepoisonlab.com/support. There's a link to it in the show notes. I will always keep this podcast free. No paywalls ever. That's non-negotiable. The whole point is to improve care for the next poison patient, and that should never cost anything to access. With this option, you can support me in making the show, and hopefully I can make more than one episode every 2 months, and you'll get benefits too. All episodes, like this one, ad-free, occasional bonus content, merch giveaways, and discounts on the Gotta Pick 'em game. Hopefully giving back some value for the value you find in the show. But here's the truth. You don't have to pay anything to support the show. Subscribing, leaving a review, sharing it with a friend, those are totally free, and they mean a lot in helping us share our message about caring for poison patients. So, however you choose to support it, at the end of the day, I'm just glad you're here. Thanks for being part of the community that makes this show so much fun. Okay, let's get to the episode. Hey everybody, you are listening to The Poison Lab, a show about poisoning for people who manage poisoning. I'm your host, clinical toxicologist and emergency medicine pharmacist Ryan, and today we have another incredible episode of Toxicologist vs. the Internet, featuring none other than Dr. Amy Zosel, a powerhouse in the toxicology world, division chief of medical toxicology at my very own Medical College of Wisconsin, and an all-around inspiring advocate for all of the people that she works with. Now, if you haven't listened to one of these episodes in the past, myself and a guest will work through some cases of real poisonings, and we will attempt to determine what the poisoning is based off the symptoms that the patient presents with. The goal is that so all of us can practice our differentials, and the next time one of us is confronted with one of these deadly poisons, it might be identified sooner. After that segment, we jump into Toxicologist vs. the Internet, where myself and Dr. Zosel answer some questions from reddit.com/r/askdrugs. The internet dearly needs a toxicologist. We cover some really interesting toxic today, like why your drug-using patient might have a fever, some common sources of over-the-counter drug misuse, and some absolutely great learning cases. I even get stumped and get to learn quite a bit about another toxin. We start the episode off hearing a little bit about Dr. Zosel's training, how she got to where she is, and what she enjoys about toxicology. If you're one of my high-yield friends, you can skip all the disclaimers and jump to minute 840 to get into the show. Or if you just want to practice your toxic differentials and go straight to the cases, go to about minute 17. And you can check the show notes for timestamps and resources related to the cases that we cover today. In the show notes, there's also some summary information about the toxins involved in our Stump the Toxicologist cases. If you scroll too far in the show notes, you're going to find out what the toxins are and you won't get to practice yourself. But I put in big highlighted letters, spoiler, before you get there. One last thing about the show notes. Alongside this episode, we are releasing a mini episode with Dr. Rob Bassett. He is the Associate Medical Director over at the Philadelphia Poison Center. During this show, the topic of mushroom poisoning comes up a number of times, and while I was working with Dr. Bassett on a different project, he gave me a great mnemonic for remembering all the different poisonous mushrooms and how they can present. So check the show notes for a bonus episode from Dr. Bassett about remembering toxic mushrooms with the Gotta Pick 'em mnemonic. Okay, before we jump in, our standard disclaimers. We're going to be answering questions on the internet from people who may be trying to use drugs for the wrong reasons. Anyone using illicit drugs is exposing themselves to risks of potential contaminants, wide dose fluctuations, and toxicities of the drug itself. While this gives us a medium to explore toxicologic concepts, we are not advocating for anyone to use illicit drugs. If you are struggling with substance use, call 1-800-662-4357 to access the SAMHSA free helpline and get the care you deserve. Second, we're going to be talking about real fatalities, and while this allows us to discuss a lot of great learning points, some of these were intentional fatalities. If you or a loved one are struggling with thoughts of suicide, someone's there to listen. Pick up the phone and dial 988 to reach the National Suicide and Crisis Lifeline that provides free and confidential support to anyone experiencing a suicidal, mental health, or substance use crisis. Please call. And for those of you out there who have been impacted by the poisoning-related death of a family member or loved one, this show will discuss poisoning-related fatalities. Due to the nature of our work, we often discuss poisoning cases with a relative casualness. It's an especially easy thing for people to do when you hear about some distant tragedy. But I don't want that to detract from the fact that each of these stories was a real person. So please take care while listening to this episode. And I want to emphasize that the reason we discuss poisoning fatalities on this podcast is to focus on what can be learned from such a tragic event and better care for that next poisoned patient. Finally, even though we will be discussing themes around identification, diagnosis, and medical management of specific poisonings, this podcast is for educational purposes only and should not be interpreted as medical advice. If you have a health question, please contact your primary care provider. Or if you believe you are being poisoned or have a question on how to treat poisoning and are located in the United States, call 1-800-222-1222 for the free public access line to one of America's poison centers that is staffed 24 hours a day by experts in toxicology who will give you free medical advice. Okay, without further ado, let's dive in. Hey everybody, you are listening to The Poison Lab, a show about poisoning for people who manage poisoning, and I have such a wonderful guest here with me today for another rendition of Toxicologist versus the Internet, someone who's been so instrumental, honestly, in my own career. I think I would describe them as they're the number one champion of other people that I know. They really make opportunities for people and work hard to make sure that those opportunities get made for them. I can disclose my bias. This is the current director of our medical toxicology group, but a really fantastic and wonderful person, Dr. Amy Zosel. So, Dr. Zosel, would you mind introducing yourself? Tell us a little bit about where you are, where you work, what you do.
Absolutely. Thank you for that introduction. That was so generous. And it is my absolute privilege and joy to be here. I am a big fan of both Dr. Feldman and this podcast. So thank you again for having me. I went to medical school at the Medical College of Wisconsin, did my emergency medicine residency at Northwestern University, and then went on to get a master's in clinical science and a medical toxicology fellowship training at Rocky Mountain Poison Center and University of Colorado, and then came back full circle home to Medical College of Wisconsin, where I am a very proud division chief for a medical toxicology division. And I work at MCW as a professor of emergency medicine and medical toxicology.
And that means as our division chief, you have an amazing job of trying to wrangle, I think it's called a BZOR of toxicologists when you have multiple, or I've also heard it called a disagreement of toxicologists, but when you have more than 3 toxicologists in a room.
I prefer a herd of unicorns. That's what herding unicorns.
By the way, if you're interested in becoming a toxicologist, what a fantastic training program that the Medical College of Wisconsin Division of Medical Toxicology puts forth in their toxicology fellowship, which you get to be trained by many of the people who'd been on this show. We are not supported by them, but I support this fellowship dearly. You'd get the opportunity to work with Dr. Zosel in this capacity, and she has so many fantastic stories. I love hearing about your stories from doing toxicology in Vietnam. I'd love to hear a little bit about what brought you into toxicology in the first place. Like, why did you did a residency? Now it's time you could go out there and become an EM attending. But you said, I want to do that plus toxicology. So how'd you end up there?
So I don't know if you know this, Ryan, but my dad was Mr. Yuck. Did you know that?
Wait, what? Really?
So my dad, he passed when I was a teen, unfortunately, but he was a pharmacist, and he would dress up as Mr. Yuck and take me to, and this is going to age me because I was a small child in the 80s, so you get an idea, but he would take me along to these health fairs that they used to have in malls.
Wow.
Set up little booths with all sorts of health information. And he had this big green face, Mr. Yuck face, he'd put on with a cape. And he went by himself, and apparently kids were crying and scared of him. So then he brought his little his little pet, little baby. And so I would hand out the stickers, and we talk about keeping poisons locked away and that poisons aren't candy. So I was exposed to poison prevention at a very young age. And yeah, so this is true. And then when I did my toxicology rotation at Toxicon, another amazing program, I went on my first day, and it was rounds, and it was some of the most amazing toxicologists in the world. It was Dr. Tim Erickson, Dr. Mark Mysick, Dr. Sean Bryant, Steve Axe, Trevon Thompson, all these amazing people. And I thought, oh my gosh, these people are so wicked smart. They are so unabashedly quirky. I want to be in this club. This is so cool. And we talked about the most interesting cases, and it was this amazing synthesis of pop culture and history and chemistry and forensics. And I'm like, I want to do this for my job. This is so cool. And I was just enthralled. And literally my first day on the rotation, I knew it was for me. And then when I wrote my essays for fellowship application, I had to say my dad was Mr. Yuck, of course. And so
of course. This was like fate from the beginning there. Yeah.
Yeah. That's stars aligned.
So for any of the interested listeners out there who are contemplating post-residency fellowship, there's a lot of options out there for people. Maybe they want to do critical care. Maybe they want to do ultrasound. Maybe they want to do tox. They're not sure what to choose. For my medical listeners, what keeps you interested in toxicology? Anything that helps fill your cup in the tox world on a day-to-day basis?
Well, I think number one is that I learn every day. There's always something new and interesting that people are doing. We get calls. I'm like, I've never heard of anybody trying to test that, or what is that, or where are they getting that? So I'm learning every day. So that constant challenge really keeps me interested and engaged. That's one. And number two, it's a great balance because we are running around in the emergency department, putting out fires, fixing things, moving fast. And that's really great and fun. And that was my first love, of course. I did an emergency medicine residency, but then I love that balance of really getting to delve deeply into an interesting case, think about it at the biochemical level, the cellular level, the patient, the community health level. We're able to really focus in detail. So it's a really nice balance of thinking styles and work patterns. So I think I love that balance, and I love that we get to do it all.
Yeah. It's so interesting, coming from the emergency department, and it's such fast thinking and real quick. And then sometimes when we're doing toxicology, you find out answers 6 months later when some lab comes back and you're like, whoa, okay, that's what that was. It's really cool having the longevity with the patients in tox and it's so interesting and endlessly fascinating. I agree. I get to learn every day. It's so much fun.
And it makes us better, right? It makes us better pharmacists. It makes us better physicians, just knowing the tox and all of that. It just makes us better at our emergency as well. So
absolutely. Okay. For the listeners, this is one of our Toxicologist versus the Internet episodes where we will review some cases of fatal or possibly non-fatal poisoning, and each of us are going to read through one case, and we're not going to reveal what the poison is. We will scrub it a little bit to get rid of any clues. The goal of this is for people to be able to practice their toxic differential. So if you are a healthcare worker, or if you're just someone with an interest in poisons and you want to be able to test your mettle, see if you can identify what the poison is based off the signs and symptoms that are produced by its toxicologic mechanism, it's, I think, a good exercise. So every time Dr. Zosel and I are together on rounds, the topic of poisoning murders comes up constantly because we're both kind of nerds and like to read about poisoning cases. And sometimes these actually come through sometimes you get consulted on a poisoning murder. And we always talk about, we don't think about it enough. There are cases of homicidal poisoning out there, and maybe we should think about it more. So I chose a theme today that all of my cases were at least attempted homicidal poisonings. So before we start off, that's it. Just don't give away the poison. And then we're going to let the other person work through their differentials. So would you like me to read you a case, or would you like to read a case to me first?
I'm happy to start us out. This is
I,
not a murder, though.
that is
This
okay. Does
it
not.
could be used for a murder. It could
It,
be.
okay. Yeah.
All right. Buckle up here. A 27-year-old male and three other workers at a construction site
Uh-oh.
gathered something they thought looked delicious,
At
made
a
it into a soup
at, at a construction site?
at a contrast. Yes. So
Okay.
it adds a little twist, maybe. But they gathered something they thought looked delicious,
Mm,
made a soup with it,
mm.
shared it amongst themselves, as good colleagues do. About 9.5 hours later, they all started having nausea and vomiting, and,
Okay.
and then went to the emergency department.
Okay. I have a lot of questions about how this soup was made at a construction site.
That I don't know. I didn't know they made soup at construction sites.
I didn't either. Maybe it's going to be a trend. Okay, construction sites are outside, and there are things. I guess it would be helpful to know the date that this happened because different things bloom at different times. But there's a really big clue here that's I always say it's actually hard to die from plants. I mean, it's not, but you eat a leaf, a twig, a berry, I'm way less concerned than somebody who takes a plant or whatever and then boils it, sucking all of the toxins out and concentrating it. So teas are a really common way that people accidentally die from plants, where they will make like a foxglove tea and they didn't realize it was foxglove and then they ditch poison themselves. So that would be something, but almost all of the things that are plant toxins will probably kick in within a few hours, like pretty quickly, especially if it's in a liquid. You're going to get really fast absorption, and that's going to, as opposed to a solid, which you'd have to dissolve first. I don't think it's a plant. There is another thing that characteristically, this is like the hallmark sign of it, causes delayed symptoms. And you said it was nausea and vomiting, or what?
Not
What were the symptoms?
for the first symptoms.
Yeah, obviously this is the golden rule of mushroom toxicity. There's a million mushrooms out there. Probably, there could quite likely be more than that. I have no idea, but almost all of them are actually not poisonous, but a few are. So that's why it's really useful to be able to rule out super poisonous mushrooms. And there's this kind of golden rule that if the symptoms start after 5 hours, it could be an amatoxin containing mushroom. And amatoxin is a really bad liver toxin. It goes into the cell and it inhibits RNA polymerase from transcribing proteins, and basically your liver dies. It's really tough because people don't present right away because they don't have symptoms right away. I've seen some deaths from this. So that's certainly on my list right now, is that amatoxin containing mushroom. I guess I'd have to know the state they're in to figure out where the amatoxin is coming from. I live in Wisconsin. We have some amatoxin containing mushrooms like Amanita virosa, which is, I think, called the funeral bell. And wait, that might be Gallerina. But okay, I don't identify the mushrooms. Uh, I'm not a mycologist, although I have gotten into some internet fights with people on the Mushroom ID Reddit, but I am not a mycologist. But I know we have a couple of amatoxin containing in Wisconsin.
Hi folks, it's Toxo. If you're new to this show, welcome. I pop in here to provide you, the wise, charming and undoubtedly good-looking listener, with some post-game insights, little nuggets of wisdom that might be useful but didn't make it into the episode. Ryan gave me this sweet mushroom forager voice module to drop some mushroom facts. Amanita virosa is one of many amatoxin-containing mushrooms, all commonly called destroying angels. Gallerina marginata, which also grows in Wisconsin, is known as the funeral bell.
The most common one people know about is the death cap mushroom, which is found, I believe, more coastally, so East Coast, West Coast. And I know there was a big outbreak of 14 people who died, 14 people who ate a death cap in California. 3 of them needed liver transplants. Right now, I'm thinking Amanita. I'm scratching my brain for something else that could cause a delayed toxicity like that. There's tons of mushrooms that cause nausea and vomiting. So usually we're like, if you get symptoms right away, that's usually a good sign. It means that you have some nausea and vomiting, and then you're probably going to be better in 24 hours. If you get symptoms after 5 hours, now I'm really worried.
Ryan means that if you experience symptoms of only nausea and vomiting right away, and no other symptoms, it probably means it's one of the hundreds of mushrooms that just cause isolated gastrointestinal distress but resolve uneventfully. So, early isolated GI toxicity probably means it's not an amatoxin mushroom. The timing of nausea and vomiting, along with the presence of other possible symptoms, tells us quite a bit about which mushroom could be responsible. It's really worth going over each one, but we don't have time in this episode. Ryan learned a mnemonic from some Philadelphia toxicologists, Dr. Robert Bassett and Dr. Richard Hamilton, called Gotta Pick 'em. Ryan is releasing the mnemonic as a mini-episode. You will find a link to it in the show notes. And in just 7 minutes, you can become a mushroom aficionado if you'd like. Better yet, visit our website and subscribe to our newsletter to receive all this information in a concise, easy-to-read format, delivered straight to your inbox.
But there is one mushroom class that causes early symptoms and late toxicity, and that is called the norlucine containing mushrooms.
Oh, yeah.
And Amanita smithiana, Proxima, and abrupta, I believe, are the 3 at least. This is way out in the West Coast, and they're ones that they get mistaken for this edible mushroom called, I think it's called matsuki. I'm butchering that.
It is called matsutake, Ryan. I can see why those people on the internet mushroom boards get annoyed with you.
But it's not that, because this is late. So there's my mini mushroom talk. I think it's probably amatoxin, but I'd like to hear the rest of the course. I'd probably check liver enzymes on this person. I would probably IV hydrate them for their nausea, vomiting, diarrhea, recommend that, and then do like CBC, all that good stuff. So anything else happen here?
No, I love your thinking. So now we're just zeroing in on one of these patients. Vital signs normal. The basic metabolic panel is normal except for bicarb of 20, a little bit on the low end, glucose 198, lactate 2.7, ALT. So you wanted some hepatic panel labs, AST 125, ALT 108.
Oh, it's a little liver sweat there. Okay.
A little liver sweat. Hemoglobin 16, the ABG, unremarkable. I think those are the significant things. So you want to hear more about the clinical course?
Sure.
Okay. The patient was given IV NAC, multi-dose activated charcoal.
Silibinin?
So, yes, the patient. Let's not give it away. You got the case.
Okay,
So good. You were so right on.
So that wasn't Amanita. Or
it was. That was exactly what it was. You were right on. So this was amatoxin. And they did give IV NAC. They gave penicillin. So they did get silibinin from the FDA.
Wow.
And fortunately, the patient continued to decompensate. He was treated with plasmapheresis. He was given vitamin C.
Okay.
Yeah.
Trace.
Fluids, as you'd recommended, and CRRT. His mental status declined. He was intubated then to protect his airway. Became hypotensive, eventually started norepi. So you see where this is going. It's not going well.
Yeah.
And then he, unfortunately, his fulminant hepatic failure continued, and eventually he was made comfort care and passed away, sadly.
Wow. That's so sad.
It's
just imagine life is going on as normal, and then you eat a soup and you die from. It's just, we all think we're going to go from cancer or heart attack or this, but there's a lot of dangers out there in the world. And I feel so bad for them.
Yeah, it's so sad. It's just goes from a nice lunch with your friends at work to this. So it's tragic, certainly.
So good reminder that there are old mushroom hunters and bold mushroom hunters, but there's no old, bold mushroom hunters. And you should always know exactly what you're eating and not get adventurous when it comes to mushroom foraging. Because there are some real threats out there.
One thing that it's good to know too, I don't encourage eating wild mushrooms. These are mushrooms that honestly, they could have a sign around their neck saying, eat me, because they look edible. They look
Right.
nothing that's looks ominous about these mushrooms. They look like friendly little mushrooms. And you just can't say, oh, that looks fine. You have to be so careful. And the other thing is that people cross continents that kind of know the rules, that have some experience with mushroom foraging, maybe in Asia or Europe, can get into trouble because some of the rules don't apply in North America
Right.
continent. So that's another thing. Just because you know what you're doing in one area doesn't mean you know what you're doing in another. You just have to be so very careful with these
Yeah.
mushrooms.
Yeah, that's a common kind of, at least clinical case description of somebody who comes from like Eastern Europe and they eat this mushroom all the time there. And then they come over here and it looks very similar. Or what's interesting is you can get regional variation of the toxins in the mushrooms too. So one might be toxic in one area, but not necessarily in the other. It's interesting. I got to show you this picture. This is so wild. One I found on one of the mushroom forums that I was getting mushroom shamed over, to be totally honest. But
I'm sorry,
anyways,
you don't deserve
so thank you. I was just trying to do good, I thought. Anyways, this is a picture of one deadly mushroom. And listeners, I'm going to put this, I'll find a way to get you this picture. But I have a patch of what appears to me to be 9 identical mushrooms. And one of them is actually a deadly Gallerina mushroom. So they can look like, these mushrooms can look identical and grow in patches with other mushrooms that actually are edible. And you just get one that can actually kill you. It's really sad.
There's enough amatoxin in one of these mushrooms oftentimes to kill a human. All it does take is one.
Yeah. Maybe it'd be worth just talking for just a second for the listeners. So we talked about amatoxin. That's one of the main toxins in this mushroom. It's the one that gets into the liver, which takes time, and then it has to shut down the liver cells by inhibiting protein synthesis. That's why there's this delayed decompensation that we see. Usually people we've had cases come in like very late because they get initial GI effects from actually a different toxin called phallotoxin. And that causes the GI nausea, vomiting. And then they sometimes will be okay for a little bit as the amatoxin is absorbing into their liver. And then the liver fails. And like every toxin that causes the liver to fail, there's this quiescent phase, as they call it. But basically, you do okay for a day or two, and then you show up in like fulminant liver failure. It's really tough. We have some treatments, as Dr. Zosel brought up. So we can give NAC to actually, NAC's good for the liver. Just gives some antioxidants. It provides glutathione, scavenges free radicals. Then we have penicillin, which supposedly inhibits amatoxin's uptake into the liver. And because of that, its benefit is the greatest right away, right? When the amatoxin is still in your blood.
Which, if you give it to rats and dogs before you give them amatoxin, they have better outcomes. But how many people are going to high dose penicillin load themselves before they unintentionally or intentionally eat a poisonous mushroom?
So wait, we should just be giving all mushroom foragers intramuscular penicillin.
You'll treat the syphilis. You will prevent mushroom toxicity.
There we go.
Lots of uses.
But nobody usually presents right away. So like it's very rare that it's going to have a really great utility. However, these cases just get so sick, we tend to just try it. And then there's also silibinin, which comes from milk thistle. And silibinin has the same kind of effect. You are trying to prevent uptake of amatoxin into the liver. So obviously it's best used right away. We truly have no idea when it becomes futile. Best guess of amatoxin half-life from what I've seen in the literature is like just a few hours. So probably by a day or maybe even up to 2 days, it's not in your blood, but we still give it. So it's just, you got to recognize that once they come in and they're sick, we'll throw stuff at it, but it's probably not going to do much. You can maybe dialyze someone if they show up within 24 hours or multi-dose activated charcoal in 24 hours to help inhibit enterohepatic recirculation. But that's like largely theoretical and almost nobody shows up in time. So this case got MDAC, right? He got multi-dose activated charcoal.
great. 60% of amatoxin is recirculated. So
That's huge.
yeah, that is pretty huge. I was, of course, reading about this, and they did mention extracorporeal bioartificial liver treatment.
Mars?
Yeah, the Mars. Yeah.
Yeah.
The Mars.
MARS stands for Molecular Adsorbent Recirculating System, and it's a fancy machine sometimes used in patients with liver failure.
As they're a bridge to transplant or potentially to do that and hope that the liver regenerates somewhat. Yeah. And then recommend cannulation of the bile duct, which they've done in done with apparently some improvement. But obviously that's a risky procedure and it hasn't really been, there's just case reports in humans on that.
Yeah.
But interesting, I guess, if you're going to try everything.
That seems wild. The idea behind multi-dose activated charcoal is that you eat the mushroom, gets in your blood, a certain amount of it gets secreted into your bile, and then you secrete it back into your intestines and you reabsorb it. So you give multiple doses of activated charcoal so that every time it's secreted into the intestines, you're actually binding it and preventing it from getting reabsorbed. I assume the bile duct cannulation is a similar concept. Prevent it from getting, that's crazy. Yes. I don't know if that's
very invasive.
Yeah.
Invasive.
When charcoal's an option.
Charcoal's a great option. It's something we know that we can do easily, that it's inexpensive.
The real treatment is liver transplant. Then we get into this weird, I'm not going to comment on how people get figured out for transplant, but sometimes they're like, they're too sick for transplant. And I'm like, but the only thing that will make them not sick is transplant. All of these drugs don't help. So it's just a precarious situation.
Ryan means most of these drugs don't help if a patient presents too late, when most of the amatoxin is already out of their blood. There are also some interesting other therapies, like polymexin, which might compete for the amatoxin binding site in the cell. But that's another story.
And you can test for amatoxin, but they're not really available. Like we are at a big urban academic medical center. We don't test for that readily. That would be a send out. So by the time you get that back, like you said, it's the patient's sick.
Right. And there is actually amatoxin tests, like point of care tests, but they're not like lab certified. I think it was made by a PhD. You can buy them online. It's like amatoxintest.com. I think it's like $300 or $200 for 3 of them. I've thought about buying them myself just because I want them, but it's not more for my little tox museum that I'm building than for anything clinical. But I don't know what the false positive or negative rate is. And it doesn't really matter because at the end of the day, we treat these basically on a clinical syndrome.
Yeah. Have you heard of the Meixner test with mushrooms?
No. What is this?
So there is a qualitative test that some use where you can actually attempt. It's not perfect. It's apparently variable in its results. So I'm not recommending this, but you'll see people say you can do this Meixner test, Miexner, where you actually squeeze the mushroom juice onto a piece of newspaper and then you let it completely dry. You drop highly concentrated hydrochloric acid onto that thing. If it turns that suggests there may be amatoxins.
Wow. Okay.
Or you could just stick to shiitakes. And
just don't eat anything that you need to do a Meixner test. Anyway, okay, great deep dive. We've talked about amatoxin in the past and mushrooms in some past episodes, so this was worth diving into. I promise listeners I'll do a quick summary at the end of the episode of what we just talked about, but that's it's really a fascinating part of tox is the natural toxins, and amatoxins are ones that are still unfortunately causing deaths every single year. So be vigilant out there. Thank you for that case. I think I've got a great case for you right now. So murder being the theme. Okay, ready?
Yes, I got.
This one's going to be really quick. Okay. So these were all real cases of homicide. And also, I'm so sorry to the people who actually had to experience these effects. It's easy for us to be a billion miles away from it. And we live and work in this industry. It's easy to depersonalize it, but my heart does go out to anyone who's actually affected by this. But let's talk about a real case because these are real things we got to worry about. So 4 individuals aged 66 to 70. I don't know why that was included. Presented to the emergency department 24 hours after consuming a home-cooked meal at a family gathering. All of them reported acute onset of gastrointestinal distress characterized by severe vomiting, diarrhea, abdominal pain, and fatigue. Symptoms seem to progress rapidly after that. And they all said that their symptoms started about 12 hours after they ingested this home-cooked meal. So,
Was it Amanita mushroom?
was it Amanita mushroom? It was.
What? We
can't
picked the
believe
same case.
Both chose a case.
Ryan thinks it might be important to point out, in this case, we are examining these symptoms through the lens of knowing it was a homicidal poisoning, which biases the responses a bit. There are many bacterial and viral causes of food poisoning that can cause delayed onset of nausea, vomiting, and diarrhea. We wouldn't assume that the average person presenting with nausea and vomiting several hours after a meal was poisoned by amatoxins. But if they reported eating foraged mushrooms, that might change the assessment.
But yeah, you chose an Amanita case. This was, I don't know if you heard about this, but there's a woman in Australia who's accused of murdering all of these people using Amanita mushrooms. She invited them all over. Now, let me do a quick clarification. I'm saying Amanita. That's not right. Amatoxin containing. There's tons of Amanita mushrooms. Some of them are very edible, and some of them are intoxicating. But Amanita phalloides is the death cap mushroom that contains amatoxin. So she was accused of adding death caps to their salad and actually ended up killing, I think 3 of these 4 ended up dying. Let me Google it real quick. Australian woman denies murdering her former husband's relatives with poisonous mushroom lunch.
Oh, my goodness.
Yeah.
Maybe she was just a bold mushroom hunter.
She pled not guilty. I don't know how they would figure this out, whether she knew they were dangerous or not. I don't know anything about the case details, honestly. It says Erin Patterson, 49, is accused of killing her former parents-in-law and parents-in-law sister. All 3 died in the hospital days after consuming a meal at Patterson's home in July. Oh, wow. Wait a minute. Erin Patterson is also accused of the attempted murder of her ex-husband, Simon, at that lunch and on 3 previous occasions dating back to 2021. Yikes. She essentially cooked this meal up. Her ex-husband, he did not accept the invitation to attend the lunch that she made, probably because she tried to murder him before. Oh, and she did use Amanita phalloides, they believe.
Wow.
I'm not sure they actually confirmed that, but anyways, we always talk about murder, and sometimes it can be as innocuous as a little lunch.
Wow. There's a lot of interesting psychology. There's a really good podcast called Killer Psyche. And she gets into the psyche, and she specifically gets into the psyche of individuals that murder by poison.
Oh.
It's very interesting. There's like certain characteristics, like they're confrontation adverse. And all of their kind of their thought process and patterns. It's in personality characteristics. It's fascinating. But
yeah, that's really a confrontation averse sounds right.
Yeah.
Now for a brief word from our incredibly generous and wealthy sponsors.
This episode of The Poison Lab is brought to you by Gila Farms.
Did you know those pricey GLP-1 injections like Ozempic or Wegovy were derived from Gila monster venom? That's right. Nature already had the solution, lizard venom. Big Pharma just added processing and probably like toxic dyes or something, and now charge you a fortune for it. The medical industry has taken advantage of a natural remedy for too long, but not anymore. Introducing Gila Farms, the revolutionary all-natural clinic where you just get bit by a Gila monster, just like a little bit, every single day.
It's so simple, just one gentle, medically supervised Gila monster bite in the morning, and boom, my appetite is gone for hours. Or maybe days? Time gets a little weird when you're in a predator-prey relationship. They tell me that's normal.
We have one motto here at Gila Monster Farms. Get bit, get fit.
I love Gila Farms. I haven't craved a snack in weeks, and the added exercise from running away from persistent Gila monsters really helps out.
No doctors, no prescriptions, no pharmacies. Just you and a persistent lizard in a room as nature intended.
They said just one bite a day, but Kevin disagrees. That's what I named my Gila monster. Kevin, he follows me everywhere. Last night he was at my window just staring. I respect him, but I fear him.
Here at Gila Farms, we know that the natural way is the best way. So check out the original GLP-1 and show Big Pharma that despite being natural prey to some reptiles, you won't be prey to Big Pharma propaganda. Call Gila Farms today to start your natural healing journey, one unsettling, legally ambiguous bite at a time.
Current rates at Gila Farms are $3,000 per lizard bite, but we will charge you more if you have more money than that. In addition to bites, you'll receive personal lizard health coaching from our certified lizard integration specialists. We are not required to disclose whether the lizard integration specialist is a lizard or a human being. If you are currently prescribed GLP-1 by your doctor for one of the many evidence-based treatments that have impressive outcome data, please do not discontinue it for this natural remedy, as it is not real. Please be skeptical of grifters selling you things only because they are natural and not made by Big Pharma, as this just means their product is completely unregulated, making it more dangerous. And that person wants to make as much money as Big Pharma. Gila Farms is not FDA approved, both because it is not a drug and because it is not real. At least, we really hope. Side effects may include nausea, involuntary leg kicking, a heightened sense of paranoia, and a permanent fear of rustling leaves. If your Gila monster begins actively hunting you, do not attempt to reason with it. If you manage to catch one, you cannot take it home. They remember faces, and Kevin does not forgive. Gila Farms is not responsible for emotional trauma, increased cardio endurance, or unexplained claw marks in your drywall.
Okay, back to the show.
I have another case that we could do.
Okay, this is exciting. Let's do it.
Okay. I think this is a good one.
Okay.
A 42-year-old woman was rushed to the emergency department after collapsing at home. Her husband claims she had been feeling unwell for several days. She's complaining of fatigue, dizziness, and nausea. And according to him, she had fainted while preparing breakfast after having some orange juice. When paramedics arrived, they found her unresponsive, but with normal oxygen levels, no visible trauma. Her initial vital signs in the ED were a blood pressure of 80/50, a heart rate of 42 beats per minute, a respiratory rate of 8, and a temperature that was normal. Her medical history was unremarkable. No chronic illnesses. She takes no regular medication.
Okay.
There's no known allergies and no recent illness other than feeling unwell for several days. And her lifestyle was supposed to be healthy.
She's been feeling unwell. Okay, I'm a little biased, right? Because this is a poisoning. When I hear collapse, I think of a knockdown agent, hydrogen sulfide, cyanide. However, there's this prodrome of fatigue, dizziness, and nausea. Carbon monoxide can do that. If nobody else was knocked down in her area, I would cross off hydrogen sulfide, I'd cross off carbon monoxide. Also seems like it's something he gave her to drink. I don't know. Maybe it's not him, but like thinking, okay, drank orange juice, still cyanide, because if she drank it, although again, he's given it away a little bit if he poisoned her orange juice. Looking at her vitals, bradycardia and hypotension, and I think, oh gosh, could it be a cardiac glycoside? That would be in my differential as well.
I can give you labs if you want.
Oh yeah, sorry. Okay, you're like Amy. Okay,
No. If there's specific things that you would want to help rule in or out some of your agents, I'm happy. So I'll say nobody else was sick.
Okay.
Lactate was actually normal-ish.
Ooh. So now I'm thinking less about cyanide. I'm thinking more about, because she would have an elevated lactate in a low bike.
Any other specific labs that you'd like?
I would like an EKG and I would like a basic metabolic.
Okay. So the ECG is pure sinus bradycardia.
No blocks.
No blocks. No.
Salvador Dali mustache.
No dolly waves, exactly. And no biventricular attack or slow wave fed, which, for the listeners, are pathognomic of cardiac glycoside poisoning. On that, the BMP is stone cold normal. So all of her electrolytes are completely normal.
Thinking less a lot about her cardiac glycoside. It's still in the differential, but usually we see hyperkalemia as a result of the poisoning of the sodium potassium ATPase. And I'm thinking more about beta blocker or calcium channel blocker, or maybe it could be absolutely alpha, like clonidine, guanfacine. That's on my list. Visine. Put Visine in orange juice.
Okay, you got it. It's fine.
Ah, really?
Yeah. This was a case of somebody, and actually disgruntled husband. It's a real case that occurred right in our state. Yeah. Eye drop poisoning plot in Burlington is the name of the actual news article. A husband poisoning someone with Visine. Fortunately, this was not fatal. The patient recovered, but they had endorsed feeling unwell for multiple days because they were continually poisoning them for multiple days. So apparently he was putting Visine in her soda. This was back in 2017, so many years ago. I didn't know about this case. I actually started Googling it, and it's relevant because we just had a big murder very near this area, probably just a few miles away, where someone was convicted of putting a whole vial of Visine into somebody's drink, and they ended up dying from it. Now, we're saying Visine. This is a brand name for an alpha-2, actually not an alpha-2. It's called an imidazoline, but it acts very similar to alpha-2 agonists like clonidine or guanfacine. And in this specific case, I think it was either oxymetazoline or tetrahydrozine. And what these do is cause you to become, they inhibit your body from sending those signals that allow us to keep our blood pressure up. They cause sedation, which can actually lower your breathing rate. We often call it an opioid mimic, but it usually has low blood pressure and bradycardia that goes along with it. Everybody's heard of xylazine, or maybe not, but xylazine's in all the fentanyl now, and xylazine's an alpha-2 agonist. It causes very similar things. In this case, I think it's unfortunately a cause of clandestine poisoning, not unfrequently because the liquid is easy to add to drinks. And I don't know if, have you ever seen the movie Wedding Crashers?
Parts of it. Yeah.
There's a scene where somebody like adds Visine to someone's drink, and like the next day they're like, oh man, that gave me terrible diarrhea.
Hey, Ryan found the clip. Here is Vince Vaughn telling Owen Wilson to put some eye drops in Bradley Cooper's drink to make him have diarrhea for 24 hours.
All right, you gotta step this up already. I'm gonna give you the damn eye drops. I don't want them. It's too hardcore. But do you want to be alone with her or not? Yes. Put a few of these things in his drink and he'll be going down our toilet seat for the next 24 hours. I don't want to do it. I can beat this guy. Let's be honorable for once.
And I'm like, that is the most dangerous medical misinformation someone could put out there, because adding Visine to someone's drink is like attempted murder. It's really incredibly dangerous. It's also used as like a date rape drug sometimes.
Yes.
So I almost didn't want to put this out there, but I think our listeners are responsible, and you can find it out there anyways. So they should probably be aware that this is something people can use for drug-facilitated sexual assault, or this is a cause of occult murdering by poison sometimes when people add this to their drink. So
don't take a drink from someone you don't know. Don't take a drink. Don't put your drink down. This is my public service announcement to all the women and men out there. Do not take drinks from strangers. Do not put your drink down at a party or a bar. Just be very aware. Yeah.
And unfortunately, this person knew the person making them the drinks. It was not ideal, but luckily they were able to identify the toxin, treat the patient supportively, and keep them alive through the poisoning. And they survived the incident, which is really great.
I'm so glad for that. I'm so glad for that. And did they do any testing, or do you know how they came to the conclusion?
I actually don't know, because typically we cannot get testing for Visine. These are not things that are readily available. They might have done a send out test somewhere to check like the urine for the active ingredient. Typically, if I find out that this is something that killed someone, it's actually on autopsy, because they have a little bit more time and more sophisticated testing that they can do, right?
There is some crime labs that will do this test. NMS, of course, does it.
Yeah.
And again, these cases they're tragic. They're terrible. We feel awful for the victims. And if the medical team had not thought about this, then this might have gone unnoticed or misdiagnosed. So hearing about these cases helps us to just be more aware of, we should look for this particular poison and things to consider in a patient that comes in altered with abnormal vital signs.
For the sake of closure, per the news article, the wife eventually saw the husband put something in her Diet Coke, which led to the arrest and identification of the toxin based on the symptoms she had been endorsing.
Yeah, we should be thinking about this poison.
Right.
Mm-hmm.
Yeah, luckily it's a pretty easy one to treat. Very responsive depressors and very, at least alpha-2 agonists. And you can even use naloxone to reverse the respiratory depression. So it looks like an opioid, and you could treat it like an opioid. And the blood pressure is not like florid cardiogenic shock usually. It's usually pretty manageable. Okay. Do you want to jump to your next case?
Yeah, so this is a case that was recommended about an hour ago by one of our esteemed colleagues.
Oh, boy. Okay.
And thank you. Shout out to Matt, PharmD. So this is a death case.
Okay.
And I will say it is not in the U.S.
Oh, good to know. That definitely
changes
changes things.
Although I suppose we could find anything anywhere. I think that's important to know because I feel like this might be tough. I think this is tough.
I love getting stumped, so I'm looking forward to learning. Let's go.
All right. Here's the case. A 53-year-old man with good health, no significant past medical history, was found collapsed in a bathroom at a public library. There was a suicide note.
Fentanyl. Sorry, just
common things being common.
I know. Yeah. Okay. Maybe not with a suicide note. Okay.
So a suicide note and a bag of leftover food were also found. The ambulance crew, so EMS, noted tonic-clonic seizures en route to the emergency department.
Okay, I'm sorry. Wait, I forgot. A bag of food was found?
A bag of food.
I feel like that's a clue.
Sometimes it is and sometimes it's not.
Okay, all right, go. Let's go.
It is what it is. It might be.
It's the history.
It's the history.
Yep.
So the patient was subsequently resuscitated and intubated following a cardiac arrest on arrival to the emergency department.
Okay. Vitals?
Yes. It does say his Glasgow Coma scale was 2 out of 15. I think 3 is the lowest we use.
Mm-hmm. Okay. Must be a different country.
Different country, but he was admitted to the ICU. Okay. I don't have initial vitals.
Okay, that's okay. So so he was found down in a library bathroom with a suicide note and a bag of food. EMS found him. Nothing notable, right, from when they found him, other than he started having tonic-clonic seizures. He didn't say he was like rigid or anything, right?
It does not say that initially.
Okay.
But he had seizures and then had a cardiac arrest.
This is always hard because, first off, when they found him, is he having a hypoxic event related to apnea? And now he starts seizing. And now our whole toxidrome is usually thrown off a little bit because once the brain has had some injury, it does all sorts of things. So it's really hard to really even narrow in. You could think about what kind of toxins cause seizures, which there's many. Bupropion is the first thing that jumps to my mind. Everybody would know about that from episode 19, a prescription for heartache and seizures. There are lots of other things. You can have a seizure from an opioid overdose causing hypoxia too, right? There's all sorts of things that can cause it. But then when I think about food that causes seizures, other than star fruit in patients with kidney disease, which is a pretty rare thing, Siku toxin, which is found in water hemlock, which can sometimes be mistaken for a carrot, but usually that seizure is refractory and does not stop. So I'm already moving away from that. But let's hear a little bit more.
Sure. So then he developed status epilepticus controlled with lorazepam. No rigidity was noted after he came out of that status epilepticus episode.
Okay. Labs?
Yes, we have labs. So his blood gas revealed severe metabolic acidosis with a pH, wait for it, 6.338.
Wow. I don't think I've ever seen one that low because I think below 6.9, it just says low.
So that's very low, right? Our enzymes don't like to work at that pH. They said renal and liver biochemistry was normal. Chemistry's serum sodium of 157, serum potassium of 4.5, 5.
Okay, that could be driven from the acidemia, though. When you have a lot of acid in your blood, your body tries to pump the hydrogen into the cells, and it does that by pumping potassium out of the cells. So when you have a low pH, you end up with hyperkalemia. I'm curious, do they have a lactate? Probably going to be high because they had a seizure, but
Not at least in this first.
okay. I have profound acidemia and a seizure. Sometimes that would also make me think about quote unquote like knockdown types of agents. It's definitely things that can inhibit mitochondrial oxidative phosphorylation, like cyanide. A real big clue here is a really high sodium. There is sodium azide, which I don't know if that really gives you hypernatremia. If you like take enough of it, I'm sure it does. But without a lactate, it's hard to really put my finger on anything.
So then it says a few hours after admission, the patient developed a fever of 40 degrees Celsius.
Okay.
So what's like 104.2, I think.
Yeah, so more pointing towards uncoupling maybe, but okay. All right.
Then he had rapid deterioration of renal and liver function, disseminated intravascular coagulopathy, rhabdomyolysis, GI bleeding, profound shock. Worsening of his acidosis and multi-organ failure. Fortunately, he did die.
Okay. The big key things to look at here are profound acidemia and hyperthermia. The multisystem organ failure tells me whatever this toxin is affects every organ, and things that affect the mitochondria do affect every organ. So I'm leaning into something that uncouples oxidative phosphorylation. If you don't know why that makes you hot, you can go back and listen to my episode with Dr. Annie Ahrens, where we called inefficient heat. And we talk a little bit about how uncoupling leads to that. I think... Oh, gosh, I don't feel like they make you collapse, but maybe he collapsed and had a seizure, but it was a suicide. Something's not fitting, but I think, like, you told me there's another country you can get aluminum and zinc phosphide in the U.S., but things that are going to make you collapse, that's certainly one I would think about. Is zinc?
You're getting closer.
I'm getting closer. Oh, wow. Okay. It wasn't seizure with a aware mental state, so it's not strychnine.
You are correct. It was not. GCS at 2.
No, 2. Yeah, that's a pretty low GCS. I really think it actually could very well be a chlorphenoxy herbicide, like 2,4-D, that also uncouples. Basically, the things that were used in like Agent Orange in Vietnam. But they end up actually being herbicides. So they used them to get rid of all the foliage so that the military could move through the trees better, but they're actually super toxic, and they also uncouple. And a big overdose would lead to uncoupling that would then lead to renal failure and all these kinds of things and hyperthermia. I will go with maybe a chlorphenoxy herbicide of some sort is maybe going to be my best guess, but I would leave aluminum phosphide on there pretty high and or zinc. But there's no talk about off-gassing or anything like that, so that would probably be more pertinent if that was the case. So, final answer, chlorphenoxy herbicide. Drop it on me. I think I'm stumped. I can't wait.
Tetramine.
Oh my gosh.
Okay, this one is really hard because I don't know if I would have gotten this, but I've never seen a case.
Wasn't there like tetramine contaminated Chinese food or tetramine murders? Yeah, here it is. New York Times, 2002. Jealous business rival confesses to spiking food in a snack shop in eastern China with rat poison, killing 38 people, mostly school children.
So sad.
Yeah, oh my gosh, that's the only thing I remember about it.
Listeners, the case Ryan was actually thinking of was a case published by the New York City Poison Center group called Poisoning by an Illegally Imported Chinese Rodenticide Containing Tetramethylene Disulfophotetramine, New York City, 2002. You can check the show notes for a link to it. Interestingly, the news article Ryan found while Googling during the show and this Poison Center case he was actually thinking of are related. The Poison Center case described an infant who was playing with a white powder from a package with a mouse on it and Chinese lettering. The infant developed refractory seizures for 4 hours, was intubated, and suffered long-lasting neurological deficits. The Poison Center couldn't figure out the cause, even after translating the words on the package. But the news article about 38 people dying from tetramine poisoning came out a few months later. The Poison Center saw that article, tested their white powder for tetramine, and it came back positive. So, While certain poisonings are more common in other countries, anything is possible anywhere in our global society.
Good case.
Again, something that we're not used to seeing, but again, we want to be able to identify it. So going over these tragic cases helps us to remember these patterns.
Yeah. Can you give me some spiel on it?
I can give you a spiel. So it's extremely dangerous. It actually was banned by the Chinese government. So this article's out of China, and they say that over 2/3 of the rodenticides in China are actually illegal and or banned. So even though the government bans it, people are still willing to use it. So the chemical name is tetramethylene dicyphotetramine. We just call it tetramine because it's easier.
Of course.
It is a neurotoxin. It binds non-competitively and irreversibly to the GABA receptor on neurons and blocks chloride channels. So very highly effective rodenticide. Doses of 5 to 12 milligrams in humans is considered fatal. So it really takes very little. The other thing, it is not easily degraded and can remain in the environment and food chain for prolonged periods. So do not eat roadkill because you could get tetramine poisoning.
For many reasons. Don't eat roadkill.
Or any dead rat that you might find in an alley in China. Don't eat it. Symptoms are usually nausea, vomiting, belly pain, and then altered mental status and convulsions soon after ingestion. In fact, the time interval between ingestion and symptom is 10 to 30 minutes. So it's really fast, really fast. The unique features of poisoning are considered to be rapid onset of seizures that are difficult to control, followed very quickly by multi-organ failure and high mortality. And they do say that many healthcare professionals do not know about this. And this is even in China where it is a problem.
Wow.
So unfortunately, there's no established antidote. Treatment includes gastric lavage, activated charcoal, seizure control with anticonvulsants, supportive measures. Best treatments, of course, are treating early and being aggressive about airway control and seizure control.
Wow. Great case. Great to learn about. Tetramine. I hope I don't run into it. That sounds pretty scary. But a lot of the rat poisons are scary. So excellent. Thank you for, picking a good one. I like that. Okay. I think, and it was actually murder themed, unfortunately. Wow. So tragically too. Once I actually read into this one, 30 kids died. All right. I don't have the emotional capacity to dive into that article right now. I want to make sure we can get to our next segment, and we only have a little bit of time left. So we had a couple of questions picked out for Toxicologist versus the internet, and they were both really good. So maybe we'll do, listeners, I wanted to do some Ask the Toxicologist on this segment, but we might make that a totally different episode. So maybe we'll just dive into our Toxicologist versus the internet. And so thank you to everyone who did send in their listener questions for Ask a Toxicologist. I promise I have teams of people diligently working on your answers, but we'll get to those on a different episode, I think. Right now, I want to jump into our next segment, Toxicologist versus the internet. So we had a couple of questions here, and I think I have a really good one. And one that I chose because I've actually gotten questions about this from my ID colleagues in the infectious diseases. They'll say, hey, if somebody is shooting drugs, can it cause a fever? And I said, oh, yeah, it depends on how they're shooting drugs, right? Like, it doesn't happen if you're in the hospital, because in the hospital, we're giving you pharmaceutical grade substances which have been tested for sterility and do not contain pyrogens, which are things that can cause immune reactions, inflammation, and fever. So this question that we have here from reddit.com/askdrugs is, what happens inside the body when someone gets cotton fever? So I wanted to talk about cotton fever. That's something that maybe some people have not even heard of, but it's a really interesting phenomenon and super useful to understand the context of fevers in your drug-using patients. And I'll just read the full text here. I no longer shoot my drug of choice, and I haven't for 3 years now, but I've always wondered what exactly happens inside the body when you get cotton fever. In the past, I've had it at least a handful of times, and it's a pretty bad feeling. If anyone could educate me, I would greatly appreciate it. Dr. Zosel, can you tell us a little bit about cotton fever?
I would be happy to. And I'm really glad that the person that wrote it is no longer shooting the drugs, because it is fraught with all sorts of problems, including cotton fever. This was initially described in 1975 by a Dr. Thompson, and it was basically first described as an under-recognized cause of fever among people that inject IV drugs. So essentially what happens is that there's cotton membrane or cigarette filters, and they use these filters to remove insoluble particles from drug preparations. And so what happens is that drug abusers re-inject trace amounts of drugs extracted from a previously used cotton filter. The thought is that the condition derives from an endotoxin released by the bacterium Patoe agglomeranes, which lives in cotton plants. And so there's a byproduct. This is essentially a byproduct of using used or unsterile cotton filters and syringes. It's not something that's spread from person to person, but it's something that you can get if you are reusing cotton filters when injecting IV drug.
Oh, wow. I didn't realize that it was a bacterial endotoxin. I just assumed it was pyrogenic stuff, like you're injecting some cotton and it's causing.
This is a theory, and so it could be also that. So I found a couple different references, with that being one of the theories.
Huh. That's so interesting. Yeah. So people basically, and it's really unfortunate, but if you shoot drugs, people are like melting things in a spoon. That's the classic, right? At least the cinematic version of how people tend to be depicted using drugs, and then they draw it up and inject it. Like those things aren't necessarily sterile, so sometimes they're trying to clean it, which is great, right? With cotton, I don't know how effective that is, but it can cause fevers, and sometimes.
And other symptoms. I actually find another article if you'd like to hear more.
Sure, yeah.
Okay, so the onset's usually 20 minutes from injection and can last as long as 12 hours. And so the fevers, so you get fevers, you feel like when we have fevers, we feel achy, we don't feel well, headache, nausea, vomiting, and body aches. And the thing is, this can be very much confused with a sepsis-like clinical picture. So it can also looks when someone comes in with a fever and they're feeling achy and they're having those shaking chills and they're just feeling so unwell, we have to consider infection, which you can also get from IV drug injection. And we think about endocarditis, infection of the heart valves. We think about skin infections. And so it's very hard to sort that out. And so a lot of times these people end up getting admitted to the hospital. They'll get IV fluids. They get antipyretics like Tylenol, acetaminophen to treat their fevers. And then they'll get put on, a lot of times, broad spectrum antibiotics, get hospitalized. And you really can't tell initially when a patient comes in if it's an infection or if it's cotton fever. So a lot of times there's a kind of an aggressive management to this problem until we know the problem, what the source is.
Yeah. Vertebral osteomyelitis or endocarditis, super common in injection drug users. And if you think about it, I guess it's the same mechanism, right? So the reason you have a fever, your immune system identifies self from non-self, the particles in cotton, as well as possible bacterial endotoxins, as well even in a regular infection where you have a bacteria, your immune system is noticing these endotoxins. It is endocytizing them, breaking them up into little things, and then creating antibodies to these antigens. And it's also sending signals, particularly to the hypothalamus. And it sends prostacyclin signals to the hypothalamus, which tells your body to raise your core temperature to make it less favorable for whatever this invading bacterial force is to replicate. So fevers are useful if you have a foreign organism trying to colonize your bloodstream and other things. And if you inject particulate matter into your bloodstream, it's going to cause similar things because your immune system is going to react. So for the listener, or for the writer-inner who wasn't writing to us, that's what's going on. It's just an antigenic response, but such an interesting phenomenon that I think a lot of people don't know about and provides an alternative cause of fever in your drug-using person. And I don't know, Just has to help broaden out that differential a little bit of what's going on. Great review. I appreciate the in-depth knowledge. Okay. I think we had one more that we were going to talk about, but I think we might be running out of time. Somebody asked, what OTC drugs can you get high off and how specifically for each one? And I think my answer to that is, sir or madam, please find a hobby. And I just don't think any of these OTC drugs are going to be worth your while. But there are lots, and we've talked about them in a lot of the past episodes, but I don't know if we'll have time. Maybe we could do rapid fire. Should we just go back and forth and go one OTC that we have seen someone try to use for euphoria, but then end up having severe medical effects from it?
Yeah, we could do that. There's two that are the most common.
Oh,
It talks about, but you go first and you.
okay. The amount of people who think that taking a lot of diphenhydramine to hallucinate is somehow pleasurable is insane to me. It's very dangerous and you can die from it, from cardiac effects and seizures. And it doesn't sound fun at all. There's the first one. What else?
Not fun. And Ryan, you and I were co-authors in a presentation at the North American Toxicology Conference, the Benadryl TikTok challenge, and how we saw an uptick,
TikTok
of adolescents that were presenting with more severe Benadryl or diphenhydramine overdoses.
Yeah.
After that TikTok challenge. And it was just interesting how the social media was affecting like the severity of these overdoses. The kids were challenged to do this and post their experience on the app.
Social media is poisonous.
It is poisonous.
Okay.
That kind of was like, what are the most common ones? I can tell you what I think they are, but what really is statistically the most common. Dextromethorphan came up as two most common, and that is a cough suppressant that can be found in a lot of different over-the-counter medications. It can be found by itself. It can be found in combination. And again, it's one of those that's oftentimes in combination with acetaminophen, which again, if you take too much of that, can easily result in life-threatening problems or death from liver injury. But dextromethorphan is the cough syrup. Can be called robotripping. They can take it in a pill form. It's called skittling. So if you've heard of these words, that's what it's referring to. And thinking about the different kind of mechanisms of actions of dextromethorphan to help explain the effects. So it's opioid, but really doesn't really act like an opioid. But it has some other special effects. You can hallucinate, you can become psychotic, you can have a lot of really negative consequences.
Yeah. It's a little terrifying. So we've had cases of people who die from trying to robotrip, and it's really sad. I saw they sell this. I don't know how the FDA is allowing this, to be totally honest, but there is a unit dosed dextromethorphan, and I can't remember what it's called. It's called RoboCough. I got to show it to you. Hold on. It's crazy. It's like a 5-hour energy of dextromethorphan. And it's like, what are you doing? How is that not clearly being advertised for misusing an over-the-counter drug? And people have died from this. Oh, here it is. Look at this. This is crazy.
Hey, it's me one more time. Ryan wanted me to let you know that you can find all the images he keeps annoyingly pulling up for an audio format show in the show notes. That includes this absolutely insane product called RoboCough, the picture of mushrooms he described earlier, and all the news articles and other links he mentioned. Anyway, I'm going to take a robo-trip back to the closet where I live. Don't get cheeky, that's how we robots describe moving through time and space. Let's get back to the show.
This is dextromethorphan right here. It's sold in a 5-hour energy type thing. There's a picture of a mouth with a tongue open that looks like it's at a rave. And it contains 450 milligrams of dextromethorphan in it. It's pretty clearly not for medicinal use, and I'm a little suspect as to how they're allowed to get away with this branding. But anyways, yeah, if you want to seize and go into a cardiac arrest from potassium channel blockade, it's a great thing. It definitely has great therapeutic value at the doses where it's supposed to be used. But this one is a commonly abused drug. What was the second most commonly abused?
Loperamide.
I had a feeling.
Which I don't know. Is it more dangerous? I think probably, but it's again, it depends. The dose makes the poison.
Yeah, I think because people use it so much when they end up using it because they can become so dependent on it, unfortunately. So for listeners interested in that one, check out our episode 4, The Rise of Lethal Loperamide. It will detail quite specifically how that is so toxic. There's a ton of things out there that people unfortunately try to use for euphoria and end up with really bad health effects from, including death. So my recommendation is going to be, don't do that. I know we don't give out medical advice on this podcast, but you could probably consider not abusing over-the-counter substances decent medical advice.
Yes, that and do not be a bold mushroom hunter. I think those are two great, just general public service announcements, because we want everyone to be well and we don't want anyone getting sick.
Yeah. Thank you so much for joining today, Dr. Zosel. It was great to get into some of these differentials and hear all about cotton fever, the NIDA top abused OTC drugs. That was really interesting. And I learned something new about tetramine today. So I appreciate you educating me on that. Any final musings you'd like to leave with the listeners about the wonders of toxicology or any?
I think we covered so much. Trying to bring it back. Don't do drugs. And don't be a bold mushroom hunter. I guess those are my mantras for the day.
I love it. Thank you so much for joining. And ta for now.
Thank you.
Okay, that'll wrap it up for this episode. Thank you so much to our guest, Dr. Amy Zosel, for joining us and sharing her expertise and wealth of experience in toxicology. I learned a lot today. Let's do a really quick review of some of the toxins we covered in this episode. We started with Amatoxin mushrooms, infamous for being one of the mushrooms that continues to cause fatality throughout the United States each year. It's not just one mushroom. There are many different species that contain amatoxin, and they don't all look alike. Amatoxin gets absorbed into the liver and inhibits protein synthesis, causing cell death, and our best chance of treating it happens early. When we think about our toxicology treatment paradigm of A, B, C, D, E, F, G, airway, breathing, circulation are usually okay until the liver fails. Decontaminating the patient, you can give activated charcoal if they show up in time, but usually they don't. And as far as enhancing elimination, well, there are potentially some roles for things like dialysis and multi-dose activated charcoal to reduce enterohepatic recirculation. However, these have the biggest role early when amatoxin is still present in the blood. How early that is really not clear. Amatoxin has a pretty short half-life, but it might be present for up to a few days due to an enterohepatic recirculation. As for F, focused antidotes, if you show up in time, we do have some things we can use. Penicillin and silibinin, a compound found in milk thistle, both inhibit the entry of amatoxin into the liver. So if you do happen to show up on time, we can maybe use these to prevent amatoxin from entering the liver. N-acetylcysteine is often given as a general liver support, quote unquote, and there's a few other interesting therapies that have been studied, like polymyxin B, an antibiotic that might compete with amatoxin at RNA polymerase and prevent it from having its toxic effect. At the end of the day, you either recover your liver or end up needing a transplant, and it's not uncommon to hear about transplants from amatoxin. That's why it's so important to identify it early. The hallmark sign of amatoxin poisoning is nausea and vomiting developing greater than 5 hours from ingestion. So if nausea and vomiting occurs early, it's usually a good sign in terms of mushrooms because it means it's not an amatoxin containing. There's other mushrooms that contain things that cause nausea and vomiting and could cause other nasty symptoms, but we can usually figure out what those are pretty quickly and hopefully get some treatment started. They're not a delayed time bomb like amatoxin.
Toxo here. And this is so important, I am killing the music. Don't forget to check out the mini-episode to hear about all the different toxic mushrooms from Dr. Robert Bassett.
Next, we explore the spiking of drinks with imidazoline or alpha-2 agonist eye drops. This is a really dangerous thing to do, despite what the media might portray it as, and it's unfortunately used for things like drug-facilitated sexual assault and homicide. Alpha-2 agonists cause bradycardia, bradypnea, and sedation. They look a lot like opioids when they show up. They even have little pupils, or meiosis. So we often call it an opioid mimic. And you can actually treat the respiratory depression and CNS depression with naloxone. Sometimes you just need a really big dose. Check the show notes and you'll see a link to a study about using naloxone for clonidine overdose. Fortunately, if you get to healthcare in time, this is usually a pretty treatable toxin where we can use vasopressors in order to manage your blood pressure, naloxone to reverse respiratory depression, and if that doesn't work, we can always mechanically ventilate. Okay, finally, we talked about tetramine, a banned rodenticide in China with devastating effects on the central nervous system. I learned quite a bit about this one. So tetramine blocks GABA receptors and causes refractory seizures and CNS excitation. Its toxidrome is very rapid seizures, something that in the US would probably make me think of, say, benzonatate, but it seems it's similar with tetramine. But unfortunately, the tetramine seizures are persistent and then leads to a rapid and aggressive decompensation. So the treatment is rapid and aggressive seizure management and good supportive care. And it's unfortunately been used as a homicidal agent in a few different instances, including one mass poisoning of over 30 people in China. I'll cross my fingers that we don't run into anything like that soon. Finally, we wrapped up talking about OTC drugs of abuse, which I think is nothing new for most of our listeners, and cotton fever, a phenomenon where people who reuse the cotton that they use to strain their illicitly prepared drugs end up getting fevers, possibly from a bacteria that's actually grows in the cotton plant. But it's yet another cause for fever in your IV drug using patient. Okay, if you enjoyed this episode, one thing you can do to support us right now is rate the show wherever you're listening to podcasts. Even leave a comment about what you enjoy. It helps us reach other people who are interested in learning about toxicology. Don't forget to follow the show on whatever you prefer for your divisive social media. We are on X at Lab Poison and myself at empoisonfarmd. We are on Blue Sky at empoisonfarmd.bsky.social. We're on Instagram at tox_talk and Facebook, The Poison Lab. You can always visit our website at www.thepoisonlab.com for free episodes, free medical games, and free resources. And even more important, you can sign up for our newsletter there to get whole episodes summarized directly from Toxo every time we publish an episode. It's a great way to keep up. Now, if you heard something in this episode that you thought needed to be corrected, or maybe you have ideas for future episodes, or you just want to share how one of the messages we shared impacted you, reach out to us at toxtalk1@gmail.com. We love getting messages from the listeners, and I promise they do all get read. Okay, thanks so much for listening today, and I hope you can join us next time. Hey, Toxo, can you play us out?
The information on this show is for educational purposes only and should not be interpreted as medical advice or treatment recommendations. Contact your doctor for health questions or call your local poison center at 1-800-222-1222. This show is owned by Clinical Toxicology LLC. It's haphazardly written, produced, and somehow hosted by Ryan Feldman, who promises he's trying his best. The views and opinions expressed on this show are solely those of the host, and in no way reflect the opinions of any organizations affiliated with him. They probably wish we'd remind you of that more often. Okay, that's all for now, Toxicologues. Don't forget to give it a share with your nerdy friends. Cheerio, mates. See you next time.
Are you sick and tired of completely unnecessary liver transplants caused by a near 100% treatable toxin, all because your patient didn't get the antidote in time? Yeah, us too. That's why we, the brilliant innovators behind Tylenac, have cracked the code. Our proprietary formula is the result of cutting-edge science, decades of research, and one collective epiphany. Just put the antidote N-acetylcysteine in the acetaminophen tablet. Seriously, people, am I taking crazy pills? Why has no one done this before? Picture this. One pill, 2 ingredients, N-acetylcysteine and acetaminophen. No unnecessary overdoses. No panicked NAC infusions. No awkward conversations with your hospital administrator about why you're throwing thousands of dollars of fomepizole at someone dying in the ICU. Oh, but wait, Tylenac doesn't exist, because apparently companies are too focused on a combo pill with acetaminophen and, wait for it, ibuprofen, because nothing says innovation like combining two things that already sit next to each other on the shelf. Ask your pharmacist today why Tylenac isn't a thing. Seriously.
This drug does not exist, and we have no idea if adding NAC to acetaminophen would actually prevent hepatotoxicity, but it sure does seem to make a lot of sense. If you make this drug, Ryan is entitled to 10% of all profits. Come on, be cool about it.
Man, last night was rough. I think I took too much Benadryl for my allergies, and boom, the Hat Man showed up in minutes.
The Hat Man? I met him once after accidentally doubling up on nighttime sleep aids. He wouldn't stop talking to me. That's why I asked my doctor for ultrastigmine.
What's that?
It's amazing. Unlike physostigmine and rivastigmine, which are limited to oral, IV, or patch, ultrastigmine has options. It comes in IV, tablet, patch, lollipop, vape, suppository, and even a smoothie. No more Hat Man visits for me or my family.
A smoothie? That's versatile. I'm definitely asking my doctor about ultrastigmine the next time the Hat Man pays me a visit.
Ultrastigmine. Ask your doctor today how to banish the Hat Man.
Ultrastigmine is not a real drug and is not available to humans living in this reality. Side effects may include spontaneous hat aversion, unexplained cravings for smoothie, and awkward conversations with your shadow. If you are currently seeing a shadowy man from another dimension wearing a hat, please seek medical help and call your local poison center at 1-800-222-1222.